Good evening, everyone. Thank you, organizers. So I'll be talking about the role of RT in malignant pleural mesothelioma. I must compliment the surgeon and the medical oncologist for setting a very nice stage for the talk. So radiotherapy is also a very loco-regional treatment, and my talk will also be a little bit, keeping that flavor in mind. So what's a mesothelioma? Mesothelioma is essentially a tumor of the pleura. So it's inside the pleura. And while, a lot has been said, but I'll just at least add that one must always rule out a lung lesion and metastasis from other solid tumors using a PET-CT scan to be very, very sure about the diagnosis. And stromal invasion helps establish the invasiveness where VATS surgery comes in, which is the reason why VATS assisted biopsy is more sensitive. And IHC, as was talked by Dr. Chopade, was, always helps differentiate between the mesothelioma and atypical pleural proliferation. These are the diagnostic dilemmas which we should always traverse properly before we diagnose it as malignant pleural mesothelioma. Having diagnosed that, while the neoadjuvant treatments optimize the patient for surgery, and I'm talking about chemotherapy here, pemetrexed-based chemotherapy here, I would like to say that the role of surgery isn't unfortunately that well established. I totally agree that empirically we would all like the surgery to be taken place because we don't have a treatment better than that. But in all the studies, it has not been shown that how much benefit surgery really adds to the survival. So this is one original article which reported a retrospective analysis of about 1,300 odd patients. And addition of surgery did not really add much survival benefit. In fact, the same has been endorsed in the ERS ESTRO guidelines in the management of MPM. And I would like to also add that while it's not only the role of surgery which is questionable, even the role of RT is questionable. So setting that stage, I would like to go to the way we generally do things, which is the NCCN way. And indeed, surgery is quite very prominent here, with extra pleural pneumonectomy and pleurectomy or decortication being the two surgeries. And indeed, radiotherapy is also an inherent part of this treatment, which is called as the tri-modality treatment, starting with chemotherapy. So let's proceed with the role of RT. But we would need to understand the role of surgery first. So types of surgery, this is the EPP, the extra pleural pneumonectomy. I guess this cartoon should be able to explain it. So here is the mesothelioma, and it has been taken out en bloc with the lung and a margin of the pericardium and part of the diaphragm. And this is how the surgery has happened. This is a very toxic surgery. You're taking it's pneumonectomy also. And then the other one is pleurectomy with decortication, which is indeed a more safer surgery, where you basically take off the pleura. That's what you do. So so what happens once the surgery is done and radiation happens? So this slide is just to give you a ballpark of how the patients behave at the end of the day. So this is how the graph will almost always look, no matter what you are doing, with a little bit here and a little bit there. That is about 50% survival at 2 years, and stage 1s and 2s doing much better at 2 years at about 70%, and the stage 3s and 4s doing much worse at about 30%. So that is what you will get by doing all your treatments. And indeed, the same is endorsed by this table, which reports a multitude of studies where neoadjuvant chemotherapy followed by surgery has been done. And you can see these key results, which are about the same ballpark that I discussed. So as I said, the role of radiation therapy is questionable, primarily because we don't have enough data, primarily because it's a very rare disease. However, this is one randomized trial, SAKK17/04. This trial randomized these patients after neoadjuvant chemo and surgery. And the benefit of radiation was not really very prominently seen, with it being statistically insignificant. Nonetheless, as I said, that due to the lack of better options, we will always go in with the maximum loco-regional treatment, just as we do with many other cancers in the body. And so what are the overall outcomes of adjuvant RT? When the intent of RT is local control and the target is pleura plus margin, and the dose is about 45 to 54 gray at 1.8 to 2 gray per fraction. This last thing of 25 and 5 I will talk about in a later slide. So this is how the results are. As I said, that you have your progression-free survival about 15 months, and your overall survival with intent to treat hovering between 15 to 20 months. That's how the patients ultimately behave. What is the so there is a new kid in the block, so-called neoadjuvant RT, and what they are doing is they are trying to do the same RT in the same way as the Swedish trial for rectum did, CA rectum did, and this is accelerated hemithoracic RT followed by extrapleural pneumonectomy. So they give 25 grain 5 fraction to the entire hemithorax, and they take up the patient very quickly for surgery. So this paper reported that quite a significant number of people could complete their protocol, and the toxicity was there. These are the grade 5 toxicities, the deaths. You can see 2 deaths which are being caused. And this is my opinion, that if you are going to use something like this, please make sure that the surgery is done as early as possible, because once symptomatic radiation-induced pneumonitis develops, surgery will be very difficult because of the symptoms. Nonetheless, this is the report with the median survival of 36 months. Looks slightly better, but it's maybe because the epithelial variants were more in this study. We can't be always very sure. So I guess with this, we understand where radiation stands. It's an empirical treatment to be given after surgery, and the idea is to create local control, which may translate into overall survival. So what is the target volume for malignant pleural mesothelioma? This is relevant for the radiation oncologists who might be listening. So it's interesting that there is no consensus guidelines for this. And most of the authors are using the RTOG consensus guideline for drawing of the pleura as an organ at risk, as a part of the OARs. So what you do is you basically draw the lung, and then you expand it 1 centimeter, you go 3 centimeters superior and inferior, and then you define the CTV inside the chest wall, and you exclude the intercostal muscles and nerves. You include, the intercostal muscle and nerves, and you exclude the vertebral bodies, sternum, skin, and other muscles. So something like this comes out. This is a web found picture. So you take about 5 to 8 millimeters into the lung as well, and this is how the CTV should look like. You should be able to appreciate that the CTV is going all the way down here. This is the point of going 3 centimeter downwards, and this is how it is seen on the lung window and in the PTV. So this is how we will get our isodose. So is there any role of including the site of drain or instrumentation in RT? Again, that's questionable, but this paper does tell us how we should be avoiding any geographic misses. So it's informing us that superior extent is at the upper border of T1. So this is how you don't miss out on the apex of the pleura, the thoracic inlet, and this is where instrumentation has taken place. This is how you must do it. Take all these muscles. Here you should be taking all these muscles. Here, this is how the instrumentation is being accounted for. You can see that this anterior edge is to be taken properly, so that because there's a lot of misses that are going to happen here, because it's difficult to manipulate the tumor close to the heart, and this is how you must draw it. And this must be the at-risk volume, which must be defined by the surgeon. So this is how the radiation oncologist will be working. So which technology for radiotherapy? Now in 2022, we all know that IMRT is the best, and we are way beyond IMRT also. But this paper is still quite relevant to be discussed, because they compared photon electron versus 3D. And what is important is that when you're using a 3D or any technique which is inferior than IMRT, you are not able to cover these nooks and corners. This is one observation which I made long back when I switched over to IMRT, that these nooks and corners were so well covered by IMRT. Look, this is for 3D and this is for IMRT, and this is the graph. You can see that with IMRT the coverage is better. This, for the non-radiation oncologist, this hump which is up here shows that the coverage is much superior. And this is with the 3D, this is lame. This is a little lame. So there is a lot of area which is getting missed. So this area is getting missed here. Certainly, you should go in for IMRT. This one comparison from one of the papers I found was that this they used VMAT 3D. They compared VMAT 3D tomotherapy, proton therapy, and it's interesting that with tomotherapy, because it's basically uh, an arc-based treatment, and even with those arcs, you are able to optimize for each slice separately. Maybe because of that, the coverage is, you're able to push in this high amount of dose of 56 gray. So this is my last slide. We should be using neoadjuvant chemotherapy, as has been very clearly elucidated before, and surgery must be optimized, DPP or thorectomy/decortication. And adjuvant RT should be done with IMRT so that each and every intended target is covered. So I guess I will stop here, and I thank you for your attention.